So most important thing about this patient, like anybody who is coming with sudden onset neurological deficit, sudden onset neurological deficit, hemiplegia, hemisensory loss, vision loss, ataxia, 99% is a stroke. You have to rule out the two things. One, hemorrhage and hypoglycemia most of the time. If you are working in the center where thrombectomy is available, then the picture of things come like MRI is needed, CT angio is needed, perfusion scan is needed or not. But the level where you are working, most of the physician with the, you want to do the thrombolysis, then only one thing is needed, that is a CT scan. You just do the thrombolysis because that is the time dependent. Why we are so successful in treating the MI patient, everybody is thrombolizing. The reason, because the physician has been involved in the treatment part. We are lacking in a neurology because physicians are not involved in the thrombolysis process. So in 1995, the NINS trial published for actylase for the thrombolysis. And I want to say, number needed to treat if you are thrombolizing a patient in 90 minutes, every fourth or fifth patient is going to improve. The same thing you are doing for the cardio, you have to, I think more than 20 patients to thrombolyze to save one life. So it's more successful over here, but it is not happening. The reason, because physician is not involved. I think your involvement is more than required than my involvement, because patient comes to me on third stage. First we'll go to family physician, then to me. So your involvement is very, very, very important. So any sudden neurological deficit is a stroke. Now we have the time frame. The patient who comes in the 4.5 hours, IV thrombolysis can be given by anybody who is trained. If patient comes between 4.5 hours to 24 hours or from 0 to 24 hours having a large vessel occlusion or medium vessel occlusion, then mechanical thrombectomy is a gold standard or the standard care of the treatment. If patient come beyond 24 hours, then we have to prevent the complication which is likely to happen in next 7 days or 10 days. Okay, that is the treatment. So the treatment is to open up the blood vessels as early as possible by thrombolysis, by mechanical thrombectomy. That is the gold standard treatment right now. And you all know, these are the studies, the open artery always does better than non-open artery. And you all know with the large vessel occlusion, like IC occlusion, MC occlusion or basilar occlusion, they have the big infarction. They have a high mortality rate in comparison to small infarction. I want to highlight one more thing. It's very commonly used drugs like a heparin, like antiepileptics, mannitol. These are really harming more in ischemic stroke. Stop using those drugs. It is not useful at all. Okay, so I want to say what should be used. These things should be used. IV thrombolysis should be used on time. If minor stroke is there or TIA is there, load with the antiplatelet, double antiplatelet, okay, to prevent the further episode, to prevent the further progression of the disease. Heparin is not going to help you. And I have seen more hemorrhages with the heparin than the thrombolysis in last 15 years. So a large vessel occlusion, they have a high mortality. So if you open up the blood vessels, these are the 5 trials published in 2015 and changed completely treatment part in acute ischemic stroke and clearly shown better result in compared to the just conservative management. So how we are doing? So I got the message around 4 o'clock from the physician, there is a stroke. He reached in our hospital, within 15 minutes the CT scan was done. It was perfectly normal. So perfectly normal CT scan with a sudden onset neurological deficit is a ischemic stroke. No need to go further. What you want to check? Nothing. A normal CT scan is an ideal candidate for both thrombolysis and thrombectomy. So we started the IV thrombolysis, the time is mentioned, and we immediately after thrombolysis, because NHS score was more than 10, if NHS score is, somebody is having the dense hemiplegia or speech involvement, usually is a large vessel occlusion. Okay, I'm not trying to teach you how to do that NHS score, okay, but clear finding. Anybody is having a dense hemiplegia, eye is deviating somewhere, speech is involved, almost is a large vessel occlusion. You just thrombolize the patient as a bridging therapy and shift the center where the endovascular treatment is happening. So after that, after starting the IV thrombolysis as a bridging, we shifted the patient to the cath lab. You can see this is the middle cerebral artery, bifurcation involved, and I placed a retriever stent. You can see a wire. There is a stent from here to here, and artery is opened up. And this is the post-procedure CT scan, and patient improved on table. She was having the left side hemiplegia. She started moving left side upper and lower limb. So this is the way a stroke should be treated. So what is the guideline says? So anybody is having a NHS score of more than 6, coming within a 6 hours, and aspect which already discussed with the Dr. Nimis, how to do the NHS score if more than 6. That is the candidate for the neuro intervention. If patient comes beyond 6 hours, we do the CT perfusion to find out how big is the penumbra. If penumbra is there, we want to open up the artery. If penumbra is not there, then why we want to open up the artery? So this is the way we are doing the, so now is it more of the tissue based treatment than the time based. But the initial 4.5 hours is a time based. Beyond 4.5 hours is your 6 hours is a tissue based treatment of the, so we can open up the artery up to 24 hours. I have opened up the artery up to 72 hours. Okay, but the guidelines say, the clear cut guidelines say up to 24 hours you can open up the artery. Another case, this guy underwent CABG, and after 2 months he was started on the dabigatran, okay, and he developed the right side hemiplegia and global aphasia. Because he was on the dabigatran, so anybody is on the dabigatran, he is not a candidate for the thrombolysis. Yeah, you can give the thrombolysis by using, first give the antidote, that is the edrasuzumab, it's coming in the Prex by name. You just give first that, then you can thrombolyze if you not have the center where the empty is happening. So, but we do, so we have not given. Patient shifted to the cath lab. I usually don't take the video before because I'm busy in managing the cath lab and everything. So this is the video before performing the endovascular treatment. You can see he is not able to move, he is not able to speak at all. And this was the, because we shifted directly without IBH thrombolysis because you had contraindication. You can see the left MC was totally occluded, and in a one pass we open up. This was the thrombus was removed, and this is the cath lab only. Immediately after thrombectomy, his comprehension was better, and he started moving. He started moving the limb. As soon as I open up the blood vessels, and after a few hours, he started speaking also. So this kind of the result we can give the patient reach on the time. Okay. So within a 6 hours, if you do the MT, mechanical thrombectomy, every fourth patient going to be normal. Every third and fourth patient going to be normal. It's better than the cardiologist performing a palm in a my patient. Another patient, very early sign, dense MCA sign. Otherwise, CT was perfectly normal. She was on the acetrom. So again, as a contraindication, MC occlusion. You can see this is the stent retriever. Remove the clot. Artery is opened up, and next CT is perfectly normal. She recovered on table. So if CT is normal, If patient is not contraindication for the IV thrombolysis, we start the thrombolysis. If it is contraindication, we take the patient directly to the cath lab. In the Western world, now people bypassing the emergency and radiology. They are directly admitting the patient to the cath chute, and now these machines having the inbuilt CT scan. They do the CT scan on the cath lab, just rule out the hemorrhage, perform the angiogram, and open up the artery. Okay? So this is the patient who came with the left MCA stroke. You can say early MCA infarction. And here the complete occlusion of MCA. But it was not a large vessel actually. This was a distal, it's a medium to small vessel occlusion. That is the M3 occlusion, middle cerebral artery, M3. So it's not a clear-cut class A evidence, but I performed the thrombectomy in the small vessel also. And it's a beyond M1. So we open up this artery, and I published around 42 cases where I performed the small vessels thrombectomy, and they did better. So now world are moving from the large vessels to the medium to small vessels thrombectomy. And this is my paper, which published last year. And this is the post-procedure CT scan. And the lady who came with the hemiplegia and aphasia doing perfectly normal. So this is over the intracranial circulation. Sometimes patient comes with the tandem occlusion. Tandem occlusion means there is a occlusion in the neck, that is the internal carotid artery, and MCA in the brain. So process is same. But in these patients, we usually check the cross circulation. Sometimes even the one artery is occluded, but because of the cross circulation from the ACOM, patient may be normal. Okay? But in this situation, you can see this is from the right IC shoot. This is the left MCA is got totally occluded. And there is a good collaterals which was maintaining, which was buying the time for me, for the patient. Not allowing parenchyma to die. Okay? If somebody is having the good collaterals, that may buy the time for the parenchyma for a certain period. And ultimately, it's lost hope. So this is the collateral which buying the time for this patient. So we open up from the neck first, and then in MCA, and this she was a principal. This is a post-procedure CT scan, and you can see in my ICU with the left side ICU occlusion, she is speaking, she is moving the limb. So this is about the large severe deficit patients, but sometimes patient may present with a mild deficit, like this guy, young guy who presented with just aphasia, sensory aphasia. He's a diamond worker actually, and at office he started geograph speech, irrelevant talk. When he came to me, you can see that IC on the left side occluded, and so we directly took this patient to the NGO. There is a severe stenosis, but there is something there, that is a thrombus. Okay? So suppose we open up, this thrombus may go up. So first we lyse this thrombus, you can see, with the intra-arterial thrombolysis, and then we place a stent. Okay? So this is, sometimes we place a stent in an acute setting also. So that is called the rescue stenting in acute stroke thrombectomy. And we have published a paper last year only with the rescue stenting refractory thrombectomy cases. And this is the patient who presented with the Jogren's speech, complete sensory aphasia, absolutely normal with the acute intervention. If patient comes beyond 24 hours, then we are using the CT preference. This is patient from the Dahod, came to me around after 9 to 10 hours of stroke onset. Our NHS score was 16. So we do this kind of the imaging, color imaging, to know how much is the penumbra. Okay? So this is the actual infarct size, and this much is the hypoperfusion tissue. It is not dead. Dead is how much? This one. But this small is not explaining the patient clinical situation. That NHS score 16 is quite high. So having the dense hemiplegia with this very small infarct is not possible. So because this is the hypoperfusion tissue which is clinically relevant and going to die in the next few hours, we took this patient and IC was totally occluded, open up these blood vessels, and this is the post-operative CT scan, and this is the lady in my OPD, nearly completely recovered. This is about the anterior circulation. Posterior circulation, we have the same kind of the treatment. This is the basilar top occlusion. Most of the posterior circulation, they have the stuttering course. So my threshold for the DSA is very low in a posterior circulation stroke. And actually in the worldwide, the understanding is not so clear. Okay, most of the people do the CT or MR angiography where actually the ostia of the vertebral artery missed. Okay, if I'm not right, and there is a thrombus there. And actually that is flowing the thrombus going in the basilar artery. So the DS is the only where we can see the ostia very well. So, and you all know the prognosis of the basilar artery occlusion. And this is the patient where the artery was opened up. This is the thrombus we removed. Patient was nearly stuporous as soon as open up the basilar top. So basilar, actually these are the 4 trials published. First 2 trial was not superior, but the next 2 trials giving the clear hope. Probably the endovascular is going to work in the posterior circulation also, the way we are having robust evidence for the anterior circulation. So the conclusion is the mechanical thrombectomy is now the gold standard for acute ischemic stroke. Only NCCT is required to decide about the MT up to 6 hours. No need to wait to see the IV thrombolysis result. You just proceed further to see that vessel is opened up with or not. And beyond 6 hours, you have to go with the CT perfusion or MR perfusion to decide about the MT. Thank you so much.
So I will start my presentation on how to decide antiplatelets for ischemic stroke prevention. So the outline of my today's topic will be single or dual antiplatelets and its indication and duration, antiplatelet use in different case scenarios, present role of ticagrelor in stroke, antiplatelet resistance, and what to do when there is a recurrent stroke on aspirin. So to begin with, we all know the thrombus is formed by platelet activation, aggregation, and thrombus formation. We have these antiplatelets in our armamentarium right now, but in common practice we usually use aspirin, clopidogrel, and in some cases ticagrelor. So my presentation will be mostly focused on these antiplatelets and their indication and the difficulties arises with the use of these antiplatelets. In my presentation, I have mostly included the guideline from 2021 AHA-ASA guideline for ischemic stroke prevention, and in this guideline they have included the class of recommendation starting from class 1 to class 2B, strongest to weakest, class 3 with no benefit, and class 3 with harm. And the quality of evidence or level of evidence is from level A to level C, with level A being the highest quality of evidence, level B with randomized trial, level B non-randomized trial, level C with limited data, and level C with expert opinion. So to start with, I will start with single antiplatelet versus dual antiplatelet in ischemic stroke. So as we know, we use antiplatelet for non-cardioembolic ischemic stroke or transient ischemic attack. The indication for dual antiplatelets are early ischemic stroke with mild stroke, that is NIHS less than 3, and high risk TIA. In high risk TIA and NIHS less than 1.3, we use dual antiplatelet. Dual antiplatelet is to be used for 0 to 90 days, but after 90 days we use single antiplatelet. Or the patient with moderate to severe stroke and low risk TIA, we use single antiplatelet. By single antiplatelet, the recommendation says we use aspirin up to 50 to 325 milligram, clopidogrel 75 milligram, or aspirin dipyridamole combination 225 milligram BD. For dual antiplatelet, we use aspirin plus clopidogrel. in minor stroke or TIA or high risk TIA for 21 to 30 days. Now, the guideline says the aspirin is, the dose of aspirin in acute phase is 160 to 325 milligram. For chronic phase, it is 75 to 81 milligram. Clopidogrel has not been specifically evaluated in acute stroke, but in long term, clopidogrel 75 milligram. Aspirin clopidogrel combination. Loading dose of aspirin 160 to 325 milligram or clopidogrel 300 to 600 milligram, followed by 75 milligram of clopidogrel for 21 to 90 days, followed by single antiplatelet. Dual antiplatelet is not recommended for long-term therapy. It is given in this guideline as a harm and with level A evidence that dual antiplatelet use for more than 90 days or triple antiplatelet therapy is associated with excess risk of hemorrhage. Now, coming to the intracranial large artery atherosclerosis. In intracranial large artery atherosclerosis, aspirin has been proven more beneficial to warfarin, so these patients do not require anticoagulation. If there is significant stenosis, that is more than 70% stenosis, then we can use dual antiplatelet for 3 months followed by single antiplatelet to reduce the risk of recurrent stroke. Then extracranial large artery atherosclerosis. After the acute phase of the treatment, if the patient requires carotid endarterectomy or carotid artery stenting, then we proceed for it, but after that only antiplatelet therapy. In extracranial vertebral artery stenosis, only antiplatelet therapy. With dissection also, if there is intracranial dissection, antiplatelet treatment. If extracranial dissection, we can use warfarin or aspirin for 3 months. For ESUS, ESUS is embolic stroke of undetermined source. These are seem to be cardioembolic stroke on MRI image, but in these cases also the antiplatelet is the only recommendation. There is no need to use DOAX or ticagrelor in ESUS. Now, coming to the present role of ticagrelor. For now, for the long time, we are using aspirin and clopidogrel only. Now, the more and more evidences are coming in for ticagrelor also. So let us see where are we standing on the ticagrelor. As we all know, ticagrelor is a reversible P2Y12 receptor antagonist. It is a brother of clopidogrel. But this is short acting. It is to be given in BD dose, and it does not require conversion from prodrug to active drug, while clopidogrel requires conversion from prodrug to active drug. The first trial came in 2016, which was Socrates trial. Socrates trial directly compared aspirin with ticagrelor. This trial did not prove that ticagrelor is superior to aspirin. So there was no difference in the recurrent stroke, MI or death. There was mild reduction of ischemic stroke compared to aspirin, but it was not statistically significant. So this trial was negative for ticagrelor, but in 2017, subgroup analysis found that ticagrelor was superior to aspirin in patients with ipsilateral atherosclerotic stenosis, whether intracranial or extracranial. So after that, the landmark study THALES came in 2020, which compared ticagrelor plus aspirin in acute phase compared to aspirin 75 mg daily. This study proved that ticagrelor plus aspirin was better at preventing recurrent stroke or death compared to aspirin alone. But this also came with significant risk of bleeding compared to aspirin alone. So after this trial, ticagrelor gained entry into the guidelines with 2B strength of evidence with minor stroke or TIA and more than 30% symptomatic stenosis on ipsilateral side. It is considered ticagrelor plus aspirin for 30 days followed by single antiplatelet treatment. But this also should be kept in mind with higher risk of hemorrhagic serious bleeding event compared to aspirin alone. Now, coming to the antiplatelet resistance. 1/3 of the patient develop recurrent stroke while already on antiplatelet therapy. partly due to aspirin or clopidogrel resistance, but mainly due to non-compliance. In those cases, we have to check the compliance rather than considering resistance and adding on more and more antiplatelets. We have to also see drug interaction. NSAIDs, particularly ibuprofen, offset the clinical benefit of aspirin, and PPI inactivates the hepatic enzymes that converts the clopidogrel to its active form. So we have to avoid PPI whenever possible. Other issue with clopidogrel is gene polymorphism. As we all know that clopidogrel requires transformation to its active prodrug by CYP2C19. But there is high prevalence of poor metabolizers of clopidogrel via CYP2C19, which is as high as 58.88% among Asians, like in Chinese population. Even in one study, Indian study is also showed 32% prevalence of loss of function alleles of CYP2C19. So these patients are poor metabolizers of CYP2C19 and they poorly converts prodrug to active drug. One study was published that showed that carriers were at higher risk of stroke in comparison to non-carriers, those who are on aspirin and clopidogrel. Even after the dual antiplatelets, they developed stroke because they were not able to metabolize prodrug into the active drug. So after this study, a CHANCE 2 trial came in 2021. CHANCE 2 trial, what they did is they compared aspirin plus clopidogrel to aspirin plus ticagrelor. But they included only the patients who have loss of function alleles of CYP2C19. They gave dual antiplatelet for 21 days followed by single antiplatelet. The results of this study showed that ticagrelor plus aspirin was significantly better in those patients compared to clopidogrel plus aspirin. But to keep in mind, these were the only patients who had loss of function alleles of CYP2C19. The bleeding risk was almost same in both the groups. So in this selected patient, clopidogrel plus aspirin can be proven better than ticagrelor plus aspirin can be proven better than the clopidogrel plus aspirin. Now, recurrent stroke on aspirin. As we commonly see in common clinical practice, we increase the dose of aspirin or we choose a different antiplatelet than aspirin. But the studies have shown that in both the practice, it is not significantly alter the course. And this area is still gray and still it is debatable what is the best regimen and what to do on recurrent stroke. We have to decide on case-to-case basis. So still, even after 40 years of antiplatelets in ischemic stroke, we have lots of challenges. We have uncertainty in different ethnic population. We still don't have best dose of medication and best combination and duration of dual antiplatelet in different groups, like with different comorbidities, different vascular risk factors, high BMI, and CYP2C19 loss of function gene mutation. We still don't know what to do when there is stroke recurrence on the antiplatelet therapy. We still decide these patients on case-to-case basis and based on our own experience. So, to summarize, antiplatelets are used for most of the etiologies of stroke. There are very few indications for anticoagulation. Aspirin is the most appropriate and cost-effective for treatment naive patients, and it is most studied antiplatelet. Dual antiplatelet for 21 to 30 days followed by single antiplatelet for minor stroke and TIA. Ticagrelor plus aspirin for ipsilateral stenosis and CYP2C19 loss of function alleles. And still we are having lots of challenges in every stroke patient is different. Thank you.
For stroke thrombolysis, and I'll begin here. So the name I'll say, not just stroke thrombolysis, hyperacute ischemic stroke by physicians in teleconsult with a neurologist or a stroke team. I think this is how we'll do it. So what I was told was we'll do case-based discussion, I'll pose scenarios, ask opinions, try to create some controversies and then have some concepts that you can all take and implement in your practice. So like just to know how many of amongst us care for new patients, like in frequency, how many patients with acute ischemic stroke do we see? Can we have just a few hands, like 1 to 4, 5 in a month? How many have 1 to 5? Okay, how many see 1 to 5 per week? Quite many, at least one every day new stroke, lot of them. So out of that, how many of them, if you see 10 stroke patients, how many undergo thrombolysis? 6 to 10 out of 10, 3 to 5, 1 to 2, 1 to 2, not much. Now I will change it. If you see 10 acute MI patients, how many are thrombolized? 11, yeah. So I think that is first thing. Second thing, where do you admit patients of acute MI? In your own nursing home in a general ward, ICU in your nursing home, or as ICCU in a hospital where cath lab is there and intervention is there? ICU. So now, what about acute brain stroke patients? So I think that is the thing I think we need to change. We have primary stroke centers and we have comprehensive stroke care. Friends, we need to wake up to acute brain stroke. There for a lot of times there has been fear about thrombolysis when we have been thrombolizing MIs for years. Now I think 2 decades we have been thrombolizing MI patients. We need to wake up to acute ischemic stroke. So if per protocol following guideline, if we are doing it, only 6% can bleed, out of which most are asymptomatic, reperfusion bleed. Only less than 1% may be harmed. It is cost effective, it is life changing. Stroke thrombolysis, mechanical thrombectomy and care in a stroke unit or center are 3 main things which have very good improvement in all terms. But it should be team care, protocol based and comprehensively done. So I'll take up some cases. So a 50-year-old male, hypertensive diabetes, comes with sudden right face, arm, leg weakness. He is able to speak and understand and his gaze is normal. The onset to time is 1 hour. So what do we do next? Okay, this is for them. So lot of times we see patients are sent to MRI centers because they all know that in the first hour CT scan may come normal and will not pick it. But here it is not that. So for first we say, is it a stroke or a mimic? So any patient with a sudden onset, balance problem, eye problem, face, arm, speech problem, remember time is brain, but don't forget mimics. Right? So seizures, history you have to ask whether there was a focal movement before the weakness or not, and most importantly things like sugar, hypoglycemia, hyponatremia, any drug sedative which the patient has taken, lot of other things. But remember, these are easily diagnosable by history and there are blood sugar at admission. People are worried that what if we thrombolize a stroke mimic? See, thrombolizing stroke mimics does not cause harm. There are lots of studies done which have shown over the time. On the contrary, not thrombolizing a stroke, considering that it may be a mimic, causes harm. So next is, so the same case, now he has sudden right face, arm, leg weakness, he is able to speak, his gaze is normal, there is no headache, vomiting, pulse is normal, blood pressure is normal, sugar, ECGs are done normal, there has been no history of seizure, fever or drug. So all the things are ruled out. Now the question which was posed was, what do we do? NCCT head, CT head and neck angio, MRI brain or MRI brain head and neck angio? Quickly can somebody shout? What do we do? So generally the impression is that we get and do MRI because CT will come normal. So important thing is for thrombolysis we need to rule out bleed. We don't need to see MRI showing diffusion, showing an abnormality. Remember, when a patient is the emergency with an acute deficit, we have to work like a Formula 1 race pit stop. Time counts here. We have to be quick, we have to fast, we have to reduce the door to needle time and improve our efficiency. So like they say, this is like 10 years back, they say door to needle time. So the moment patient enters in emergency, to thrombolytic drug is given should be less than 1 hour. Now they say it is less than 30 minutes. This is how people have been changing their practice. Why? Because time is brain. For whole day, for 2 days, cardiologist would be banging you. Time is muscle, time is muscle. But if the brain is not giving signal, that muscle is also not going to work. We all know this, the importance why there is a penumbra, and if we can open up the vessels, we can save patients. And this is time dependent. So if we can thrombolize within 90 minutes, the NNT is 4 to 5. If we delay up to 180 minutes, NNT reduces to 9. And if we go up to 4.5 hours, it becomes 14. So the more early we are, we have to, we'll see more benefit. So it's like when a patient comes with acute stroke, it is like a maze, and we have to rush through all this. So getting a CT is very important, and taking a stroke team in consult. We can easily do teleconsultation nowadays. That is the importance now. So now we do, so and not just do a NCCT head. We also need to see what the vessels are, because that helps us in deciding management or also in deciding prognosis. There are some conditions where MRI would be required, like a partial recurring deficits, hypoglycemia plus deficits, history of seizure, a subacute onset of symptom. When we have also differences like abscess, vasovagal lesion, CVT, other things, and when there is a wake-up stroke and we don't know the exact time of onset of the stroke. So sometimes some centers may have preference, but otherwise get a CT head and neck angio, that will give you a lot of ideas. So for all patients less than 6 hours, CT head and neck angio would be the workhouse. Remember, for patients who come after 6 hours, still they are in window for management, not for thrombolysis, but for large vessel is up to 24 hours, and even later on, if collateral circulations are all seen, Mukesh will talk about that, they are candidates for intervention. So now the same patient, CT head and neck angio is done, it is normal, there is no bleed, angio is normal. What do we do now? Great, very good. So not go for MRI, don't go for EEG, don't start aspirin, clopidogrel, don't give the citicoline, paracetam, all those things. This patient needs thrombolysis, just roll out a free contraindication. So there are only two absolute contraindications. There is active bleeding in the brain or there is active bleeding outside the brain. Beyond that, all are relative criteria. You can involve the stroke neurologist and they can help in guiding the patient. The others are there, I will not go in detail for lack of time. So what do we use? So there are two options. One is altiplase, one is tenecteplase. So one is a standard tested molecule, one is a biosimilar in India. So like what are the differential things? One is the third generation, one is the second generation. TNK has the advantage that we can give it fast just as a bolus. All the other things are all okay. So it depends on what you are using. So how I will break it down in just one slide. So it is very simple, like what we do it with MI. So the patient comes, first 10 minutes, just do a triage, have your systems in place. In the next 15 minutes, do the blood pressure, sugar, weight, NIHS, ECG, and quickly send the patient to CT. And at the same time, parallelly discuss with the family. By 15 minutes next, get the CT reports ready, get the patient read by the most neurologists who are interested in stroke care will know how to read CT. The radiologists also will do it. They have that, it is in their phone now. They can read it even at home. And then if it is, you are going TNK, just it is a bolus. You have to just give. If you are going to give TPA, so first it will give 0.9 mg you will give as a bolus, and then the next 10% you will give as 1 hour infusion. So what are the caveats of these? So only India has a biosimilar drug approved, which is TNK. The tenecteplase that you give for pulmonary embolism or MI is not the one which should be used for stroke. The dose is 0.2 milligram per kilogram in India, while the whole world gives 0.25 milligram per kilogram. And if you are using TPA, that is 0.9 milligram per kilogram. Of that, 10% you give as bolus, and the rest 90% for infusion. When we use TNK, when patient has large vessel disease and you want to take the patient quickly to the cath lab and do mechanical thrombectomy, TNK will help save life. It will be a bit cheaper also. But for TPA, what are the benefits? A uniform stage dose which is proven, it is not a generic. Here you can drip and shift the patient. So you give the bolus of tenecteplase, then you can shift the patient if it has a large vessel occlusion to a center where mechanical thrombectomy is possible. So like art of thrombolysis decision making, there are some things which are important. So there are patients who will respond very nicely, the ones who come very early, who are young, whose glucose and sugar are normal, who are on the protocol and have moderate to severe disease. The ones where thrombolysis may not work are the ones who come late, who are old, have very high sugar, have bad CT, right? So there are dilemmas are there, but you can always involve quickly on a phone a neurologist who is interested in acute stroke care. Then they will improve. So the last case, 63, hypertension, diabetes, smoker, sudden right face arm leg weakness, but with loss of speech, lost comprehension, is looking towards the left. You are called by your patient's relative. The patient is yours, you are following them up, that he has developed this. So now where will you take him? To a nursing of a friend nearby, to a hospital which is multi-specialty, which has CT, MRI, but only general neurologist. And then there is a comprehensive stroke care center with a 24-hour DSA and mechanical thrombectomy facility. What will you do here? See, very good, because he has problem suggestive of cortical involvement. So it is likely to be left MC infarct. But there are ways by which just even laypersons can pick up a large vessel occlusion. So you can use a ray scale. All mobiles, they have this MedSeal calculators. You just apply the clinical simple information and you will know which of the patient large vessel. So if you have a patient with large vessel, try to shift them to a comprehensive stroke care center, where they'll require not just thrombolysis but even mechanical thrombectomy. So there is this whole pathway. I think for lack of time, in 15 minutes, I think we can cover this much only. But you can take a photograph of this. You can keep it in your mobile phone. So whenever such a scenario comes, you can use it as a ready referral. I think I'll thank you.
So as a physician, we are managing intracerebral hemorrhage also, right? And very less learned topic by the physician. So let us learn in a simple way. So common questions among physicians are about ICH are what is the cause of ICH, angiography is needed or not, surgery is needed or not, anticoagulation, antiplatelet to restart or not, statins to continue or stop. So these are the common questions. We will try to answer these in a simple way, right? So intracerebral hemorrhage is primary or secondary non-traumatic hemorrhage in the brain. The term hemorrhagic stroke include ICH, subarachnoid hemorrhage and hemorrhagic conversion of the ischemic stroke. We will discuss only ICH. ICH is due to bleeding into the brain. It contributes almost 15% of the stroke annually. So ICH can be spontaneous or primary ICH or secondary to some cause like vascular abnormality, primary or metastatic brain tumor, CVT, hemorrhagic transformation of ischemic stroke. So for this spontaneous ICH, primary ICH, there are two pathophysiology. First commonly is lipohyalinosis and second one is cerebral amyloid angiopathy. So lipohyalinosis means concentric hyalinized deposits in the vascular wall. So it generally occurs in the penetrating arterioles, in the basal ganglia, thalamus, brainstem and the cerebellar nuclei. So if the hyaline deposit occurs, the structure of the vessel is deformed and it might burst and cause the intracerebral hemorrhage in this location. If it is chronically occluded, then it will cause the lacunar stroke in the same region. As we all know that these are the common region for the lacunar stroke also, but pathophysiologists are same. And the major risk factor for this are hypertension, diabetes and age. Second pathology is beta amyloid peptide deposits in the arterioles of the leptomeninges and cerebral cortex and cerebral hemorrhage. These will cause the spontaneous lobar hemorrhages. So around 50% of the elderly people have this CAA. So basically it is causing the lobar hemorrhages with cortical microbleeds in the cortical areas with cortical hemosiderin deposits will effectively diagnose the cerebral amyloid angiopathy as a cause of this ICH. So this is one CT, one MRI SWI images which is showing the cortical microbleeds in these patients. So for the etiology, as we all know that hypertension is the most common cause of this hemorrhage, ICH, and it will cause non-lobar ICH. Four sites we have to remember is basal ganglia, thalamus, pons and cerebellum. Other risk factors are CA, antiplatelet patients on drugs like antiplatelet, anticoagulation, cigarette smoking, chronic alcoholism, decreased LDL and tricks, sympathomimetic drugs and old age and male sex. as we all know, it is an emergency, so we have to be very specific on history. We have to take, I will tell you what specific history you need to ask. We need to ask time of onset of the neurological symptoms. We need to ask for the headache at onset, whether headache was there or not. If it was there, then was it a thunderclap headache or acute onset with progressive increasing intensity. It will change the treatment part. So we have to ask for the seizures, like activity was there or not, loss of consciousness, vomiting, previous history of ICH. Drug history is most important, and ask for the antiplatelets, especially anticoagulants like heparin, NOACs, vitamin K antagonist, and last dose taken for these drugs are also important to ask. GCS, vitals including blood pressures, as we all do that. Important blood investigations like CBC, INR, APTT, RBS and other routine investigations as we all do. Factor 10 inhibition levels for patients on DOACs is not available routinely, so it is not to be done in emergency basis. For imaging part, CT scan is the imaging of the choice. We need to do a CT scan as like in acute ischemic stroke also. So we need to see the location, mass effect, markers of hemorrhagic expansion, hematoma expansion, and the size of the hematoma. So we'll see as we all know that on CT scan hemorrhage looks white. It looks like hyperdensity is seen. So ICS most common cause is blood pressure, and imaging modality of choice is CT. So BPCT we need to remember that it occurs at the basal ganglia. These four location, basal ganglia, pons, cerebellum and the thalamus. Thalamus looks like egg-like structure approaching each other, and the lateral to the thalamus the basal ganglia is there. So we know that gangliocapsular and the thalamic ICH is very common. So we need to remember that hypertensive ICH occurs at these four locations. This is the lobar ICH, frontal lobar ICH, and this is also frontal lobar ICH secondary to cerebral amyloid angiopathy. Also, we need to see if the on CT that is there any sign of hematoma expansion. Will this hematoma will increase in near future or not? This is the island sign where the small hyperdensities which is not attached to the main hematoma. If it is more than 3 in number, then it is very likely that this hematoma will expand. We need to monitor closely. And also the irregular border like this hematoma is very irregular. Heterogeneous density is also a sign of hematoma expansion. These are other signs like swirl sign, the black, the hyperdensity is inside the hematoma. This is also hyperdensity is inside the hematoma. This is also heterogeneous hematoma. These all signs suggest that this hematoma might expand. This is blend sign. There is relative hyperdense area adjacent to the hematoma, and this is very important. This is blood fluid level seen commonly in anticoagulation related ICH. So it is very having worse bad outcome. This is also important sign seen in CT angiography. So if we have done CT angiography and there is contrast leaking in the inside the hematoma, it will look like a spot here. So initially this hematoma size was 20 ml. After 24 hours, patient is having spots and it increases to 110 ml. So it is an important sign for hematoma. This is also a spot sign. We at 24 hours the hematoma expanded, right? So now how to calculate the ICH size? So it is how to calculate the ICH. It is simply calculated on CT scan. So first we have to see the length of the hematoma. So first we have to maximum length of the hematoma, and perpendicularly we have to measure the width of the hematoma in centimeters. Remember, it is in centimeters. And the height of the hematoma in the coronal sections. So ABC divided by 2 simply will give you the volume of the hematoma. So with this information we can guide the patient's prognosis in early. We can discuss it with the relatives, because you can see here this is the ICH score which includes GCS, ICH volume, as we can we already seen how to calculate whether any intraventricular extension is there or not, infratemporal extension is there or not, and each. So if the ICH score is less than 2, 1 or 2, then we can see that 30 days mortality is 25% around. But if it increases to 3, suddenly mortality increases to the 70%, and all 4 to 5 score, mortality is very high. So we can guide accordingly. So these were about the ICH and when we should suspect that there is some cause of this ICH. It is not just a spontaneous ICH. These are the some features, like if the patient is young patient, there is no history of hypertension, patient is having headache before at the very early, history of new onset neurological symptom preceding the ICH, thunderclap headache at the onset, and history of ICH previously. And otherwise there is some imaging feature on CT scan also which can raise suspicious of the secondary ICH, which is edema out of proportion to the size of ICH. Hemorrhage appears in the vascular territory, enhancement of the intracranial vessels, multifocal hemorrhage, so isolated intraventricular hemorrhage, and multi-stage bleed in a same hematoma. So this is a case where the hematoma is seen, but there is very huge edema out of proportion. So MRI brain was done, which showed the contrast enhancing mass tumor at the same region. This is another case which hemorrhage is seen, but in the vascular territory. So this is the primary ischemic lesion which converted with having hemorrhagic conversion. This is multifocal hematoma. MRI was done and which showed multiple metastatic enhancing tumor. So these were about very important thing is to look for the vascular abnormality, think of the vascular abnormality. If the CT scan is showing following features, we need to look for the vascular, because the treatment modality totally changes. So commonly if we see subarachnoid hemorrhage, enlarged vessel or calcification around the ICH, hyperattenuation within the dural venous sinus, then if the cortical vein is seen, unusual hematoma shape, intraventricular hemorrhage, and these features are there, then definitely we should go for angiography. And if the CT angio or MRI angio suggestive of some vascular cause, DSS should be performed to confirm and to treat it, the vascular pathology. So this is a case of in spontaneous IVH without any parenchymal lesion, definitely DSS should be done. This is a case of young elderly female with suddenly developed drowsiness and irritability. She had IVH. So after 5 days, she suddenly developed new focal deficit. So MRI was showing this posterior circulation stroke. And the DSA was done, which showed multifocal stenotic lesion in the basilar and the vertebral territories, which was treated with intra-arterial nimodipine, and patient showed gradual improvement in the focal deficit. So definitely we intraventricular hemorrhage without any parenchymal, DSA should be performed. Repeat DSA, we are suspecting vascular abnormality and DSA is negative, then also DSA should be repeated 3 to 5 months, because sometimes the with acute ICH, the vascular lesion can be obscured. So now we'll come to the venography. When venography is to be ordered, so patient, because it is very important to see for it, because it has the totally different treatment. This is the only hemorrhagic ICH where anticoagulation to be given in therapeutic dose. So some clues like young patient with hypercoagulability, like patient is on OCPL pregnancy, anti-plus syndrome, sickle cell disease, patient is having cranial and ear infections, patient has CT, patient has lobar hemorrhage and gyriform hemorrhage, bilateral hemorrhage, edema out of proportion to hematoma, and gradual onset of headache, and then neurological deficit. That is also important. Patient ask for the patient's headache, type of headache, and the manner of the headache. So these are different type of hemorrhagic, venous hemorrhagic infarction. This is the lobar hemorrhage. This is the juxtacortical hemorrhage. This is the gyriform hemorrhage. Small gyriform hemorrhage is there with juxtacortical hematoma. And this is some subtle SDH, which can also sometimes be seen with the CVT. This is a case of bilateral venous hemorrhagic infarct in young patient with superior sagittal sinus thrombosis, which was treated with anticoagulation and intravenous thrombolysis. So now will we see, this was all about the how to see the and go for the cause. Now we'll see the management. So we need to, as you all know, that BP is very important to control. So as ASS suggests, if the BP is between 150 to 220 at presentation, the target should be 140. Less than 130 is harmful. and the target should be achieved within 1 hour. If as we all know that if the cerebral perfusion is equal to blood pressure, intracranial pressure, if the patient's hematoma is very large, then definitely the cerebral perfusion will be impaired. So in these patients, practically we don't have ICP monitoring. So ideally the cerebral perfusion pressure should be monitored, maintained between the 60 to 70. But practically in these cases, BP should be lowered less than 220 immediately, and then gradually lowered up to 140 to 160 target. If the patient deteriorates in between, then antihypertensive should be stopped for some time. So many intravenous antihypertensives can be used. For the intracranial pressure, we have to give some head elevation to the patient, hyperventilation with intubation and mild sedation, and PCO2 to be maintained to 28 to 32, and hyperosmolar therapy, mannitol and hypertonic saline to be used transiently only, and early prophylactic hyperosmolar therapy has no role. ICP monitoring, ASA recommends if the patient GCS is less than 8 and impending herniation, it is to be done. And for the hemorrhage, very important, if the patient is having is on anticoagulation, reversal is very important in these cases. If the patient is on anticoagulation, reverse, and on the warfarin, vitamin K antagonist, if the INR is 1.3 to 1.9, then 4-factor PCC to be given in 10 to 20 international unit per kg dose, and if it is more than 12, then 25 international unit per kg, along with the 10 mg of vitamin K. Dabigatran and factor 10 inhibitor, Epixaban and rivaroxaban, reversal agents like idarucizumab and andexanet alpha is available. It is to be preferred. And for the heparin, protamine to be given. Platelet transfusion is not recommended unless the surgery is planned. Anti-epileptic therapy prophylactically not to be given, only if seizure is happening, then not to be given. For the surgery part, Dr. Sandeep Shah will take this part of the surgery part of the hemorrhagic stroke. So generally, if the patient is having hemorrhage and if the patient is having ongoing clinical deterioration and location is near the cortical surface, then it is recommended. Surgery should not be done who are either fully alert or deeply comatose. If GCS 3 and 15, it is not to be done. So here is one case, we will not go in detail in this case. For posterior fossa, the threshold for surgery is less. So if the patient is having cerebral ICH of volume more than 15 ml or thickness 3 centimeter, deteriorating neurologically and brainstem and compression and developing hydrocephalus, immediate surgery to be done. Now important thing is when to restart anticoagulation. If the patient is having mechanical heart valve, you can start anticoagulation therapeutic dose in 1 week after the ICH if the CT shows that hematoma has stabilized. If patient is having AF and indicated for anticoagulation, you can start in 4 to 8 weeks if the hematoma is stabilized, and DOACs are better than the vitamin K antagonist if possible. And large left arterial appendage occlusion is preferable in high risk patients. DVT prophylaxis you can start in 72 hours if ICH is stabilized. Antiplatelet part, if the patient is having atherosclerotic cardiovascular disease, and you have to give aspirin, and if the patient is on primary prevention for atherosclerotic disease, then look for the risk factor. And if the patient is having stent in the cardiac stent, and you can start the antiplatelets within few days. But definitely, if single antiplatelets therapy preferred over the dual antiplatelet therapy. For statin, it is only to be restarted if the strong indications is there. Less compelling indications like isolated dyslipidemia, and for those who has multiple lobar ICH and risk for ICH, avoid statin, and also avoid high doses and prefer hydrophilic statins like rosuvastatin. Antihypertensive, what will the target for future blood pressure target? Reasonable to maintain the blood pressure 130/80 for long-term management to prevent the hemorrhage recurrence in these patients. So So take home messages are there. As a physician, always see the CT scan of the patient. Try to find out the cause of ICH, especially always check, seek a cause if the ICH is not in the BPCT location, as we already discussed. Do appropriate further imaging if needed. DSA can be useful to confirm and treat vascular cause. BP, intracranial pressure monitoring, hemostatic treatment is individualized. Thank you.
I won't go into the major detail of your mechanism of strokes, diagnosing and everything. Now we are going from stroke or stroke wide to stroke grade, which is considered to be hemorrhagic stroke. Now our role comes as far as the ischemic stroke. You must have door to needle, but we are always worried from door to OT times. For them it's 60 minutes, we require 90 minutes from door to OT. We need PT-INR, we need some basic triple H markers to take the patient in also in OT. If we comes after 90 minutes that the surgery required, then it will be 3 hours. So always to the physician, first message, we always prefer that you should also take that 15% of the patients who require surgery in hemorrhagic stroke. As you know, the artery burst, whether it is hypertensive or due to underlying pathology of aneurysm, AVM, malignancy, bleed, or some with bleeding tendencies, the symptoms usually remains the same, but as the hemorrhagic stroke, the patient may be in comatose, there may be pupil inequality, there may be respiration distress, then CT is going to be with red hemorrhage, right? We usually prefer CT scan in early. For the ischemic strokes, as everyone has told, door to needle, we try medical thrombolysis, thrombectomy, but still in certain patients where all this doesn't work, there may be some kind of infarct. The timing to operate in a non-responded ischemic stroke is very important. As early as we operate from the early signs of deterioration, the results are always better. If we operate from the first signs of deterioration to 24 hours, the results are always better. It can be either decompression, craniectomy, right? And then we offer 6 to 12 weeks cranioplasty. These are the few CT examples, pre and post decompression. Usually these patients' arm, you look into the hand and that the decompression amount required is the palm of the hand of the patient. The hemorrhagic stroke, there are so many things which require in case of hemorrhagic stroke and the type of the hemorrhage, whether it is only lobar, whether it is cortical, deep-seated, BPCT, IVH, without extension, expanding, non-expanding. Once you categorize the type of hemorrhage, then there are so many things we can offer. Sometimes only need bedside EVD in the ICU for IVH. The patient improves, stabilizes, and can be managed medically. Certain patients with hemorrhages like this, cortical, some people use for the open surgery or microscopic surgery, but now we have a very good large number of patients, those who has been treated with minimal invasive neurosurgery, where we can offer them 3 types. Previously we were doing open burr hole and putting a drain and everything has been in a cortical thing, but where the hemorrhages are deep-seated, we calculate everything, we take 2 targets, put stereotactic guided aspiration catheter. Initial trials were with the streptokinase, then were with the urokinase. There are trials which are going with the actylase also, the MISTI trial, where the stereotactic frame is applied, the catheters are put, and then the intra-clot actylase has been given. You know, the chances of lysis of thrombolysis, the clot in next 2 to 3 days or more, and the patients are cured with the minimal invasing, avoiding second cranioplasty also. That can be also offered with the endoscopy, where you suspect some minor element of active bleed or that, where you can put your endoscope and try to see it, remove the clot, and try to control the hemostasis. These are the few pictures suggesting the endoscopic procedures. We have navigations where we can utilize the navigation on a peroperative mode. It is almost like a peroperative CT where we can utilize the and come to know. Now the second part, the ICA subarachnoid hemorrhage. There can be traumatic, non-traumatic subarachnoid hemorrhage. Sometimes can be aneurysmal bleed, that the clipping and aneurysm can be offered or coiling of aneurysm can be offered. Both are time tested, both clipping and aneurysm, both have their own promoters and papers suggesting the goods and bads. But as far as the clipping is concerned, it's a newer technique coming in the way with hands-on experience and experience. The only thing is that the chances of rebleeding is more in case of coiling if it is not completely occluded. As far as the clipping is concerned, the morbidity or maybe the surgical risk is high, or maybe the 90 days mortality may be little higher, but overall they are apple to apple comparable in our scenario. In Indian scenario, the cost is the limiting factor for both comparing the clipping and the coiling. This was the meta-analysis of the endovascular coiling versus microsurgical study, and they concluded that the coiling was significantly associated with a better life of quality, a lower incidence of post-operative complication, and high rate of mortality, reading or hydrocephalus, and a lower rate of complete occlusion of the clipping. Similarly, the neurosurgical clipping provides better results in terms of mortality, rebleeding, and retreatment. Endovascular coiling is a better surgical technique in terms of post-operative complication, favorable outcome, and rehabilitation. The last part of the stroke, we need to prevent it, we need to assess the risk, and we should help to prevent the stroke rather than it occurred. So most important, prevention program, do not smoke. Smoking can be more than double your risk of stroke. Avoid passive smoking too. Eat a healthy diet, and that includes plenty of fish, fruit, vegetable, beans, high fiber greens, breads, and olive oil. Eat less salt too. Get exercise on most, preferably all days of the week. Your doctor can suggest a safe level of exercise. Stay at healthy weight. Control your cholesterol, blood pressure, diabetes. Keep your HbA1c in range. Limit alcohol. Take daily aspirins or other medicines if your doctor advises. Avoid rather than getting a sleep. Now, how we prevent in a surgical way? Depending on your carotid Dopplers, we can offer them a carotid endarterectomy or the stenting. Same again with the clipping and coiling. Both are time tested, almost with 99 super specificity, sensitivity, and where you take the opinion and help. But still, the New England Journal of Medicine suggests that among patients with symptomatic or asymptomatic carotid stenosis, the risk of the composite primary outcome of stroke, myocardial infarction, or death did not differ significantly in the group of undergoing carotid artery stenting and the group of undergoing carotid endarterectomy. During the procedural period, there was a high risk of stroke with stenting and a high risk of myocardial infarction with endarterectomy. So again, there is a catch whether you will go for stenting in acute stroke or you will go for a carotid endarterectomy in acute stroke. We usually do with the shunt or without shunt. Our results are comparable with both the standards. Thank you. So again, one more thing, always remember door to OT time is also important. There is entity like stroke rate. We need certain preparation time, and there are surgeries which are available both in hemorrhagic and non-hemorrhagic stroke also.
Good evening, all of you. We are gathered here for a neurology update and specific emphasis on acute stroke. You might have gone through program planner. There are few lectures by our colleagues for the treatment of acute stroke, like thrombolysis, endovascular treatment, surgical treatment, antiplatelet treatment. But for every option, good imaging is required, and CT plays an utmost important role in imaging of acute strokes. All physicians should know basics of CT imaging and acute stroke. In next 8 to 10 minutes, I will show some slides which will help physicians for the diagnosis of acute stroke. As you all know, stroke is third most common death worldwide, common cause of death worldwide. Estimated stroke-related death is around 1.2% of total death. Time is brain. Every second counts. It has been proven that early diagnosis and early treatment is the key to successful outcome. And CT scan plays the utmost important role in early diagnosis, as CT is widely available, fast, and affordable modality. This is its main advantage. Stroke. Broadly, we can divide stroke in two types, mainly the non-hemorrhagic stroke and hemorrhagic stroke. The prevalence of non-hemorrhagic stroke is far more than the hemorrhagic stroke. Now I will discuss more important 4 P's of acute stroke imaging, that is parenchyma, pipes, perfusion, and penumbra. Parenchyma to assess early signs of stroke and rule out hemorrhage. Pipes or vessels to look for thrombus in extracranial and intracranial circulation. Perfusion to assess cerebral blood volume and cerebral blood flow. And penumbra, that is tissue at risk which can be salvageable with early treatment. CT can be used as non-contrast CT, CT angiogram, and CT perfusion. Non-contrast CT to assess parenchyma for hemorrhagic and non-hemorrhagic stroke. CT angiogram to see the extracranial and intracranial vessels for possibility of thrombus. And CT perfusion to assess tissue at risk, which is most important. First thing is the non-contrast CT. First and foremost indication of non-contrast CT is hemorrhage, to rule out hemorrhage. Second, if there is no hemorrhage, then we should look for the early signs of an acute infarct. Other are subacute infarct and chronic infarct. What are the early signs of acute infarct? These are obscuration of lentiform nucleus, insular ribbon sign, dense vessel sign, and cerebral swelling. Now I will show some of the cases which shows these points in detail. This is a 52-year male patient presented with acute left-sided weakness. What we can see in this axial CT image is large area of hyperdensity, that is in the right basal ganglia. Hyperdensity or brightness, that is intraparenchymal hemorrhage. Second case, this is 60-year-old female presented with acute right-sided weakness after 2.5 hour onset of symptom. What we can see in this axial CT scan, there is no hyperdensity. That means there is no hemorrhage. Then we should look for early signs of hemorrhage. What I have pointed out, in that left lentiform nucleus, there is some gray white differentiation loss. So this is early sign of MCA infarct. This is obscuration of the left lentiform nucleus. Third case, this is a 73-year female, came with left hemiparesis after 3 hours after the onset of symptom. What we can see in axial image, there is no hyperdensity. That means there is no hemorrhage. So we should look for early signs of acute infarct. what I have shown in this image is there is some hypodensity in the region of insula, that is a part of basal ganglia, and this is insular ribbon sign, which is an early sign of acute infarct. In this image, this is the 85-year-old female presented with change in mental status after 4 hours. What we can see, there is a dense dot in the region of basilar artery and hyperdense vessel in the part of proximal posterior cerebral arteries. And on below images, we can see some hypodensity in the posterior cerebral circulation. This is dense vessel sign. This is also an early sign of acute infarct. Another patient, this is 62-year male, presented with acute left side weakness after 4.5 hours. What we can see in this axial CT, non-enhanced CT, there is some hypodensity, which is shown by the arrow. There is an linear hyperdensity in the proximal M1 part of MCA. This is hyperdense MCA sign, which is early sign of an acute stroke. Now the patient came, 49-year-old female, came to hospital after 2 days. What we can see in this axial CT, there is no hyperdensity, that means there is no hemorrhage. What we can see is very well demarcated hypodensity in the region of right temporal lobe. This is early changes of subacute infarct. Now 60-year female with left hemiparesis since 6 months. What we can see in this axial image is large area of hypodensity involving right frontal and temporal perisylvian region. This is a chronic infarct. Now some of the stroke centers tells about the aspect score. The NCCT or non-enhanced CT, we can calculate the aspect score, which have prognostic value. The score less than or equal to 7 predicts worse functional outcome at 3 months, as well as chances of symptomatic hemorrhage. Now I will tell you about something about the CT perfusion. By CT perfusion, we can differentiate between the dead area, like the core of infarct, and penumbra. Penumbra is the tissue which is at risk of infarct. These are the few maps, brain maps, what we calculate through perfusion imaging, CBF map, MTT map, and CBV map. I will show one of the case for the perfusion imaging. Like this is 50-year female, fluctuating left facial drop and left arm weakness for more than 3 hours. What we can see in this plain NCCT, there is very small hypodense area in the frontal lobe. And on perfusion images, there is large area of abnormal signal intensity on MTT, large area of abnormal signal intensity on CBF imaging, and small area of abnormal signal intensity on CBV imaging. That means the core of infarct is small and penumbra is large. That suggests that this patient is ideal candidate for thrombolysis therapy. Another patient showing same findings. There is large penumbra, which we can see a large area of penumbra and small area of ischemic core. So this is also ideal patient for thrombolysis. Now the match defect. That means all 3 maps, if they show a similar finding and similar area of involvement, that means there is no penumbra and there is large core of infarct. In these kind of patient, the thrombolysis will not help much to the patient outcome. Now the CT angiogram. We did CT angiogram by giving contrast, IV contrast to peripheral line, and take the small sections of area of interest and take the imaging of vessels. It shows mainly the site of occlusion. It rule out arterial dissection. It grade collateral blood flow, and it characterizes the atherosclerotic disease and atheromatous plaques. It also shows whole brain perfused blood volume map. These are the CT angiogram images which show there is complete cut off of right MCA and there is visualization of thrombus within. This is the extracranial angiography which shows a significant stenosis at the origin of right internal carotid artery. Now I have included all important 4 P's, that is parenchyma, pipes, penumbra and perfusion. Now few takeaway points from my talk is CT is widely available, quickly performed and affordable modality. CT can differentiate hemorrhagic and non-hemorrhagic infarct. It can assess extracranial and intracranial circulation for evidence of intravascular thrombus, can show global cerebral blood volume and flow. It assists tissue at risk of dying of ischemia if continues without recanalization of intravascular thrombus. Again, remember, time is brain. Act as fast as you can. Thank you.